And we were talking beforehand that, you know, when we talk to patients about immune checkpoint inhibiting therapies, they're like, well, I'm already getting that IV. Why is this different?
Yeah.
And why does the timing matter? Because my oncologist doesn't seem to care. They give it to me some appointments in the morning and some appointments in the evening. So could you touch a little bit, deeper on these immune checkpoints and timing and delivery and why this is all different?
Yeah. Well, I think, the one thing is that when you look at like what oncologists are able to offer patients, and again, it's what's available in their arsenal. You're mainly looking at, PD-1 inhibitors. You're also looking at, CTLA-4 inhibitor, potentially, in Yervoy or tremelimumab. But, and then you got dual lag, which is technically a PD-1 LAG-3 inhibitor as well. So there's really only 3 immunotherapy targets, PD-1 or PD-L1. You could have drugs that hit both sides, CTLA-4 and LAG-3. When you look at your immune checkpoints, there's many, many more, right? I mean, so you've got, B7H3 being a big one, and we use drugs for that. You've got things like ICOS, Vista, TIM3. There's several other checkpoints that all could be in consideration of those. So, I think the idea, well, you see a lot of times with the PD-1 and, is that doctors are looking to say, well, does a patient have PD-L1 expression? Should they get Keytruda or Opdivo? And that's, not a great marker because one, it's dynamic. It could change. It could be there. It could not be there. The other is that it's probably more expressed on probably the outer edges and surfaces of the tumor, which is probably not where the biopsy was performed, because biopsy usually punches into the tumor and then you take a sample. So you're probably not getting the outer edge. So if you sampled that, maybe they are PD-L1 positive, but you didn't because you probably got more of the middle of the tumor. You don't even really know what you got. I mean, that's when you get the biopsies, and there's more to it than just PD-L1 status. But for what we do, we use lots of immunotherapy. So for a doctor to tell a patient that because they're not PD-L1 positive or they don't have mismatch repair deficiency or other things like that immunotherapy doesn't work, is like saying, okay, you got a bacteria and you checked it, it's resistant to penicillin. Oh, no antibiotics work. No antibiotics work, right? Penicillin's antibiotic. No, that does work, right? But that's not true, right? Because we know that's not true because we know we have many types of antibiotics. And so, you can have others that can work. It's the same thing in cancer and with immunotherapy. There are other immunotherapy agents. Unfortunately, most of the doctors will not have that in their arsenal like we have. So they're limited. They're telling the people what they know, but the reality is that if you have other immunotherapy drugs, you can make these work.
Well, we've been talking about circadian rhythm as it relates to immunotherapy, going back to the 2019 research paper there with Ashdown. But here, this recent paper here that I was talking about, they're talking about the rhythm, the expression up and down regulation of actually PD-L1. So as you said, and you see this from the estrogen ER positive with breast cancer, right? It used to be that it had to be considered positive where it was expressed above 10%. Now you're seeing that, 1 to 10% is probably positive. The question is, did we hit the part? Did we target the part on the biopsy? Did we miss it? And then now it's what we now understand, at least related to the PD-L1, there's a time where it's upregulated and there's a time where it's downregulated. And then what you were talking about is the heterogeneity of the tumor, which means that tumor is not a complete clone of itself. There's lots of different pockets there, one that may be expressing PD-L1, one that may not be expressing. Then there's a whole question of, is the entire tumor upregulating, downregulating? So is that oscillation of the PD-L1, is it uniform? The answer is probably no. So then we have to look at it through that prism. And the great conclusion here, PD-L1 expression peaks during certain phases of the circadian cycle. again, correlating it with the abundance of the myeloid-derived suppressing cells in the tumor microenvironment. So as you were so eloquently saying, is that, look, just because you have a biopsy that says negative PD-L1, we can't exclude that as something that we don't target, especially when going intratumor.
Yeah, yeah, yeah. I obviously, and they've known for years that, PD-L1 status shouldn't be the, make or break. Should you treat the patient with immunotherapy or not? Though it's been looked at that, and oncologists have that kind of ingrained in their mind. So, but they're dealing with a different situation. In the future, things will change and there'll be more agents, and this won't be the case. But they're seeing it through the old perspective, and so yeah, we don't worry with it. PD-L1 status doesn't make a difference. I mean, we use PD-1 inhibitors in really the majority of cases at some point. Now there's argument, or certain cases maybe do you not start with PD-1 inhibitors and you transition into them. That's certainly reasonable in some situations. The one concern with PD-1 inhibitors, and like why you just wouldn't give them to everybody with cancer, is that, well, certainly systemically, intravenously, they have side effects and that much more than what we would see giving it into the tumor. But the other thing is that there's occasional risk of this hyperprogression that I think is associated with PD-1s, and the PD-1 people will not want to talk about that. But I think there's a situation where PD-1s express on lots of immune cells, and again, depending on the timing, right? You're giving weapons, but you give it the wrong time, you may be giving it to the enemy, and I think that's maybe the situation with certain cases of hyperprogression, and so that's why they're trying to figure out why to which patients to give these to and not just to give them to everybody. Now again, I think it's unfortunate that patients don't have access to more options of immunotherapy and to going into the tumor and things like that. Let's say they're only mainly restricted to Keytruda. Maybe they're lucky they could get Yervoy. Maybe they're lucky they could get Opdualag. But unfortunately, they're restricted. I mean, I think patients don't understand in the healthcare system. There's a menu, there's codes, and that's what you can offer. You can't really offer other stuff. The drugs may be there, and maybe there's other stuff that you could use, but there's no payment for that, and there's no way to get around it. And so it's not like even if the patient actually, if they're in a insurance and they're wealthy, they could pay for it. They don't understand. They're not going to be offered these things either. This contract.
That's offer. It's not even offered. It's not even offered.
Yeah. I mean, so many people are missing out, and unfortunately, the way the whole cancer care and healthcare system is set up is really bad, and has really put us in a situation to make it hard to give patients good care. That's why I do a lot of my practice outside the country, because at least it's less expensive, and I can do more things and be more innovative. I could do some of the stuff in the U.S. and it could certainly, it's more expensive. But yeah, there are certain things you could try to do. Regulatory wise, is not as much of a problem anymore. I mean, there's lots of things that you could do. But I mean, really, the realistic thing would be, why don't insurance companies come and say, hey, let's pay you for how long the patient lives. So the longer they live, the more money you get paid, right? That's how it's, I mean, should you get paid for like your success? Right. Yeah.
Reimbursement on outcomes. That's a novel concept.
Exactly. Yeah. I mean, that's what the insurance needs to be. But instead, it's like, no, run up a bunch of these procedures and other stuff, give patients drugs that extend their life 2-3 months, and cost hundreds of thousands of dollars.
And throw a party for a increase in survival of 2.2 months. Now, granted, that's great, but what if we change that to 2 years, 20 years, by really focusing on trying to expand outcome? We celebrate, Jason. I wouldn't even say we celebrate mediocrity there. We're celebrating a step when we should be saying that's not enough. We must do more.
Yeah, I know. I mean, the whole thing, and that's for me in the future. That's what I would love to see, where you could have a system that the pay is based on the work you do. You cure the patient, you get paid. You don't cure the patient, maybe you don't get paid. I don't know, because um,
There'll be a lot of doctors who don't get paid, Jason.
well, yeah, I mean, but
Sadly.
yeah, it's if you took your car to a car place to get it fixed and they don't fix it, would you? Other services. So I mean, we should be that way, but unfortunately, it's not. And I don't know. Hopefully, the system will change. I mean, for us, I mean, in the future, we want to be able to do, some of this on our side. But obviously, there's a whole, there's insurance, the hospital systems, all this other stuff, that it's not just us. It's hard to change it. We do what we can. But yeah, I mean, like for me, first thing is that treatment starts at the biopsy. I mean, you do not biopsy a tumor unless you're going to treat it with something.
That's revolutionary, Jason. That's revolutionary, because nobody does that. That when you first presented that concept to me, I was like, brilliant. That makes perfect sense. Yet it seems lost on everybody else.
So yeah, and I've had these discussions. Obviously, we develop drugs and even devices and stuff like that, and we have our own biotech and device company. And I went to my device expert people, and I'm going to say this publicly, but this is not really a problem because I filed patent for this stuff. But said I want to develop a biopsy needle, where the biopsy, when you do it, it also does pulse electrical field, so that you automatically biopsy and pulse field the person at the same time. Pulse field, you do small areas, not going to cause a problem. Most of the tumor, I mean, again, when you're biopsying something, greater than 90% chance that's cancer. Like, we have pulse field devices now. You can do endoscopy, bronchoscopy, so all the areas of biopsy that we normally see, this could be connected to. So, my feeling is that what speeds that you, and I think you obviously need to inject some drugs into it too, not just pulse field, but you do the biopsy and you pulse field it minimum, right? In a perfect world, you'd inject some drugs. And of course, the people that are the big experts on this, and because again, like, when you try to develop this type of thing, you got to look at where you're going to get your funding, all this stuff. I mean, because we're discussing trying to do clinical trials. We'd like to do clinical trials where we do pulse field at the biopsy. But the problem is getting the funding, right? Who's going to fund it? And but that's what we want to do. And so one of the things that they came up with is, they said, hey, but here's the problem. If you do that, the payers are not going to pay for the pulse field, which they don't pay much anyway. I mean, like, they don't pay enough to make these things worthwhile. I mean, the needles cost more than what they pay, but they're not going to pay for the pulse field unless the biopsy is positive, right? So if you don't have positive biopsy, it's not going to pay you, so you're not going to get payment, right? So you have no way to do the biopsy and pulse field at the same time and get paid. I said, well, just take your chances, right? I mean, we know 90% plus are going to be positives. Just have the insurances only pay if the patient was positive. If their biopsy's positive, pay. If it wasn't positive, so I don't know. I mean, that's all something that has to be worked out over many years.
Paid for DCIS versus intraductal carcinoma or mucoid. So it'd be interesting if they probably would. They probably say, no, we're not paying for DCIS.
Yeah,
we're going to pay for invasive. So
yeah,
I mean,
you could pick and choose. I mean, generally for me, if I'm biopsying, let's say, a breast, I generally know the difference between DCIS and an actual solid tumor. I mean, I'm not going to usually get those confused. For me, I'm usually biopsying stuff I know is positively cancer. And though it's interesting because our MQSA, the quality assurance for mammography, requires you to have a certain number of benign biopsies, right? I mean, like, that you should be biopsying benign things, because it's if you're only biopsying just cancer, then you're probably missing some. So they ding you if you don't have biopsy normal stuff. And in a regular, I don't do this anymore, but in my regular practice before, I was obviously biopsying lots of fibroadenomas. We knew they were fibroadenomas. We knew they're not going to be cancer. I was like, I can tell you 99% sure that's not cancer, but we're going to biopsy it. And that's a lot of those cases. But I know when there's cancer. I mean, the doctors, we know. We know that's what's really cancer or not. I mean, sometimes you, like the patients, and that's you put them in that scare thing. I mean, like you got the patients getting biopsy, but you say that's a fibroadenoma. But now the patient's all scared. They're getting biopsy. You're working them up for nothing, and you made them all scared for nothing. And you could just easily reassure them from the start. I mean, that's what I would do. I would reassure them from the start. Hey, look, we got by rules. We need to biopsy this, but I'm going to tell you it's not cancer.
Let me wrap up here. It's been a great conversation, I think, and what it's also showing here too, when you're talking about the biopsy and treatment, the innovation that you're going to find at the Williams Cancer Institute. It's not just with the innovative approach; it's the innovation of every opportunity is an opportunity to target the tumor, even with a biopsy.
Yeah, I mean, I think that's where we're making our biggest mistake in cancer care right now, is that we're going in there and we're biopsying the tumors and we're not treating something, giving something. Look, it could be flu vaccine, hepatitis. Look, that's one of the things. That's another thing I said. Why don't you ask the patient, hey, do you need a vaccination? You want a hepatitis B vaccination? You want a HPV? You want something like you can inject it into the tumor at the time of biopsy.
Okay, you brought that up. So people, there are a lot of people out there that's like, whoa. Okay. The phrase, the term, the word vaccination has gotten misused and thrown. Unfortunately, politics has gotten in there, and we won't go there here. Maybe one day, but not right now. But explain why a vaccination like a flu vaccination can actually help the immune system intratumorally.
Yeah, and I think one thing you want to make a distinct thing, because particularly this always pulls in the COVID stuff, because the issue with the vaccine is that if you inject it into the muscle and it creates an immune response locally in that muscle and goes nowhere else, that's probably okay. If you inject it and it goes elsewhere in the body, which sometimes it does, and it binds to other spots and it creates immune responses in those areas, that can be problematic for the person. I think that is the issue with certain vaccines, in my opinion. However,
why the flu vaccine in the tumor? I mean, what? Because
one flu vaccine seems to have less issues. I mean, it's been around a while and seems to be relatively safe. And we know that there's studies that were done that showed that giving the patients flu vaccines, injecting the flu vaccine into tumors, improved their immune responses. This is like proven. But yeah, I mean, any sort of vaccine, the old measles vaccine was actually pretty good. We used it when we used to be able to get it. You can't get it anymore. You can only get the MMR. The rotavirus vaccine, which is an oral vaccine, and I learned this from my colleagues in France who were doing some studies with it, is very immunogenic, and you can actually take the oral version, you can inject it into tumors. But yeah, you could, or you can inject ivermectin, or you can inject various things. You could, but one thing is you could go in there and say, look, I'm going to inject some stuff that whether you have cancer or you don't, not going to really cause you problems, right? I mean, do you want to be vaccinated against the flu? Do you want to be vaccinated against hepatitis B? Hepatitis B vaccine has CpG, and it's TLR agonist. That's a component of some of our immunotherapies. I mean, a lot of these agents have things that boost and stimulate the immune response, and so that vaccine put into the tumor, hopefully staying in the tumor, right, is creating that immune response there. I mean, the question is, I can tell you, I could probably inject the COVID vaccine into tumors, and I will generate immune responses in the tumors. The reason we haven't really done that, we do other mRNA technologies, is, it should work, but again, we just worry about those off target, because that spike protein getting away has been sort of the concern, and so we don't do that. But you could do that type of thing. Yeah, I mean, I guarantee if you inject COVID vaccine in the tumors, it probably will be immunogenic.
Yeah, and it definitely would. That's the issue, is I think the spike protein, how it migrates, and that's the big concern. It's been shown to accumulate in brain tissue, and and this is where it's like, gosh, I wish we had the research early on. But we don't want to go down that road, at least right here. Wanted to wrap up just with a few quick questions, and then your not just some statements, and then just your take on it, because I think it ties into this, and then we'll wrap it up. The clock, this is a quote, the clock affects innate immunity by regulating time of day, dependent production and trafficking of cytokine, chemokines, as well as immune cycle maturation and tissue infiltration. So would this mean, Jason, that if the patient got a immunotherapy aligning with their circadian rhythm of the immune system, that we might see more immune cell infiltration and thus more swelling associated with imaging?
Yeah, I mean, certainly. So, I mean, there's definitely, if you can get the timing right on certain things, you'll get some improvements. Again, we found it like kind of challenging and problematic trying to do all the time, and that's why we sort of reset the time, because we're like giving stuff and like just we're making our own time on this. So I think we kind of actually override the clock, but yeah, if you're in a situation, particularly if you're working with like limited agents, like single agent immunotherapy like Keytruda, if you could time them.
So here we're talking about immune therapy, but here's another quote. Studies have provided compelling evidence that morning administration of chemotherapy can mitigate side effects and enhance treatment response across diverse cancer types. So it seems like it doesn't just apply to immunotherapy, it applies to chemo as well.
Right, yeah. I know, and I know there was like some groups that were doing a lot of work of, trying to time chemotherapy and still do that type of thing. So,
and of course, as they were looking at the 2019 study, they were looking at radiation. So clearly that lies there as well. And finally, immune checkpoint inhibitor studies are limited with the exception of retrospective analysis of multiple tumor types where, get this, afternoon dosing of immune checkpoint inhibitors was significantly associated with shorter overall survival.
Yeah.
I mean, that we're not just talking about, okay, we have more side effects. The injection in the afternoon, they had shorter overall survival.
That's interesting, and we try to do our procedures in the morning, so at least finish by early afternoon. But yeah, it's there's all sorts of things. I mean, gosh, we could go on forever. I could tell you tons and tons of stuff that we figured out, little things that we think make things better. But yeah, it's an interesting point.
Well, that's Jason. That's the innovation. That's why I love working with you. It's the innovation in ideas and purpose that then you bring to practice. And though there may be people out there that say, "Oh, we do this," I guarantee there is no practice that brings the innovation of ideas and purpose to practice today like that which we do at the Williams Cancer Institute. It's not. It truly is the future today.
I mean, I personally would love it if other people were doing it, and I'd be happy to teach other people. But the thing is unfortunately, they're not. I mean, there are a few people that try to say that they're doing the same thing because they don't understand what we do, and they don't understand that we're far more advanced than anybody really could be. I mean, because we develop cancer drugs, we have access to lots of things, and we're in a situation that people are just not. I mean, we're fortunate that we've been able to get in this situation. But yeah, I mean, we hope to put everybody in this. We want to bring this to everybody. We're not trying to keep it to ourselves. I mean, we want everybody to have this, and that's why we do the podcast. That's why we get the information out. We obviously hope the patients are listening, but we hope some doctors are listening, and we hope that patients will educate their doctors.
Amen.
Patients can go back and tell their doctors, because I think that's a lot of it is really important, where we need the patients to actually educate the doctors and get the patients to get the doctors to understand that they need to get on top of these things.
Well, Jason, that's a great point. Whether it's patient or doctors, how do they find out more information about the Williams Cancer Institute?
Yeah, so I guess mainly through our website, williamscancerinstitute.com. So that's has all of our stuff. I think we're getting ready to try to do some updates on that, hopefully, but it's still got all the pertinent information and all our contacts.
Well, Jason, thank you for joining me on this episode where we dived into that one study called it the periodicity of the immune cycle. The immune cycle fluctuation, most would know it as the circadian rhythm, because we dove deep into these couple studies, talked about the clinical implication as well as the application as it relates to precision cancer care. We need your help. See, the innovation that we provide at the Williams Cancer Institute, we don't want, as Jason said, we don't want it just to be confined to us. We want it across the United States, across the globe. So we need your help to share this information out there. Family, friends, loved ones that could benefit from this information. Subscribe and share this to those loved ones so that you can be the force multiplier of change to actually, as Jason said, influence your doctor, bring them to the table of innovation. And you're finding it here on this podcast. Jason, thanks again for joining us.